Good afternoon, good evening, good morning, or good day to wherever you are in the world. Welcome to Rhythm Interventions Online. This is the live course which brings you everything that you would expect from a congress, apart from the carbon footprint and the jet lag and the cost. We've got some amazing talks today, and we have, as usual, the opportunity to jet around the world to see world-leading experts operate and demonstrate their techniques for managing complex heart rhythm problems. Just to remind you, this is a purely live course which is free online, and we have delegates from every continent in the world apart from Antarctica joining us. So we're very excited to have you with us today, and I hope the program today will be as interesting as it was yesterday. Today we are focusing on complex arrhythmias made simple. Let's take a look at the agenda and what we have in store for you today. So, welcome to session 1 of day 2 of Rhythm Interventions Online. We are going to start with 2 fabulous talks, and first with the wonderful and brilliant Isabel Deisenhofer talking about VT ablation, technologies and techniques. What do the trials tell us? Over to you, Isabel.
Yeah, thank you, Richard. And I think it's a wonderful course, and I want to congratulate already now everybody. I want to go directly to our topic because I was asked to talk about a topic that I feel is quite, let's say, large to cover, and these are my conflict of interests. So when we talk about VT ablations, it's mainly 2 topics. It's about mapping and ablation. And what do we really use now? And if you look at the different mapping technologies that we use now, you have, of course, all the bunch of pre-procedural things that we could do, like image-guided ablation, like integrating MRIs or CTs. And then in the lab, we have the possibility to have then high density or high resolution mappings, best, of course, with an automatic annotation that helps us find our way through these 4,000 points that we acquire in a very short time. Then there are some strategical decisions that you want to take. The one is, do you want to do a substrate guided mapping, or do you want more to map during ongoing VT that, of course, will entrain then all the problems that you can have with ongoing VTs and the hemodynamic support that the patients would need. And then, of course, last but not least, epicardial mapping. And the same is true for ablation. There's one big question about the timing of ablation, which I'm not going to address today. And then there is this large question of what is the strategy, how to guide my ablation. Is it more scar guided? Do I want to dechannel these scars? Or is it more about the local electrogram that I can maybe see looking for lavas or late abnormal ventricular activations? And then the whole bunch of what to use as an ablation energy. And I think, as you can see, I felt a little bit overwhelmed then when I discovered that I had to talk about this in 11 minutes. So I'm not going to really address all of this. I'm just addressing the ones where I think that we have newer research results that are maybe interesting. And one of these is a meta-analysis that looked at the benefit that you get when you have an image-guided ablation. So you have a pre-procedural imaging and even intra-procedurally, maybe a high-resolution mapping. And is that really helpful? And if you look at the older ones, studies that you see on top of that page, and I shortened that list because it's a bunch of publications, very large, you can see that, okay, we can do a conventional ablation without any imaging. But if you look at the VT-free survival, these studies that you see in the lower part of that page fare really better. And I think that's one of the lessons that we learned. You cannot have too much imaging in VT ablation. You can only have not enough. And so it really impacts also then a hard endpoint like the VT-free survival after ablation. So you're asked to do it. Then looking at the next topic that I think was quite interesting was how can we look at slow conduction zones? And we have here two maybe concepts that are, well, not really diverse, but are adding one to each other. The one is the approach that the Bordeaux group published back in 2012, where you look for these lavas, these late abnormal ventricular activations in sinus rhythm, and then maybe pace also a little bit. But the group of Katja Zeppenfeld, I think, then really refined that and showed that you can do a pacing with an extra stimulus and provoke then the demasking of these abnormal spikes by this extra stimulus mapping, and then do a comprehensive 3D mapping with these deep, what they call deep RV extra stimulus map. And what is the result if you do so? Well, you can appreciate that these slow conduction zones, to identify these slow conduction zones and then to eliminate these by ablation is always helpful, no matter if you do a more conventional lava approach or if you do this more time-consuming approach where you really map by introducing an extra stimulus. In both studies, the addition and the complete elimination of these strange electrograms was important and did contribute to the success. Then there is that, as I mentioned, this large question, this almost fundamental question, should I map during sinus rhythm or during ongoing VT? And then use this VT and do an activation mapping. And there's been a publication from the group of Antonio Berrezu from Madrid. And I think it's very interesting because, to be honest, it fulfills all my prejudices. There were over 400 patients included, typical population for VT. So the ejection fraction was around 38%. Most of these patients were on antiarrhythmic drugs and had an ICD. And the group then from Antonio Berrezu, they did not induce the VT before ablation. They just did a very extensive substrate mapping in sinus rhythm and ablated then without having induced anything, and induced only afterwards to be sure that they got rid of that VT. And if you look at the results, it's very encouraging, because when they managed to eliminate completely the substrate that they identified in sinus rhythm, they have very good success rates, whereas when they did not really ablate all of this, then of course there were a lot of recurrences. If you look at the whole graphs of results, you can appreciate that the main discriminators were that these patients maybe had a COPD or anything else, but the substrate modification only in sinus rhythm without without induced VT was enough to help these patients. And there's another study where we could see that if you do then an extensive induction maneuver after the ablation in 62 patients, that was, then it's even more helpful, because these patients will have a better outcome than the ones where you did a limited induction maneuver after the end of the ablation and then looked for the follow-up of these patients. So there are these 5 studies that we have for ablation in ischemic cardiomyopathy, and we see that we can reduce the ICD therapies by these ablations. In the ischemic group, we can reduce hospitalization, but not the all-cause mortality, and that is something that we always have to keep in mind. We are quite good at reducing shocks, but not at reducing the mortality in ischemic VT. And if you look at the non-ischemic VT, and I think this is still a landmark study from the Leipzig group in the HELP register, you can see that non-ischemic cardiomyopathy is even worse. So what about these non-ischemic cardiomyopathies? And there's a very nice work now from the, I'm sorry, I missed one slide here. From this year, 2 years ago, where the people could find out that the VT ablation success in non-ischemic VT is depending on the etiology of these VTs, and worst, and that's completely okay with my feeling, is sarcoid. And best are the RVC patients, where we have a good plan when we can go for epicardial ablation. So etiology is really decisive in these non-ischemic VT patients. And I want to show you one example for the ablation techniques and how we can maybe have better ablation success. This was a patient with a VPC from the LV Summit. And we could introduce an ablation catheter far into the CS and ablate from there, but could not suppress the ablation. And the same was true from endocardially with another ablation catheter. We could not really suppress this VPC. What we then finally did is that we did a bipolar ablation, and you can appreciate these 2 ablation catheters, the one deep inside the coronary sinus and the other one from endocardially in the LV. And finally, by this bipolar ablation in between the 2 tips of these 2 ablation catheters, then get rid of that VPC. So I want to conclude that in VT ablation, the mapping of this arrhythmogenic substrate is still a challenge, and to add 3D mapping, image integration, electrogram analysis is really helpful. It increases the success rate of our VT ablation, to really maps as much as you can. Ablation of the substrate in sinus rhythm is promising, and it's maybe even enough, and we don't have to induce extensively VTs that then are not hemodynamically sustained, so that we can really go for it and not bring our patients into danger. And when it comes to VT induction as the end point at the end, you should better be aggressive and really try to get rid of these VTs. And be sure that there are no VTs left that are inducible. We have quite satisfying results for VT ablation in ischemic cardiomyopathy regarding the ICD therapies and the hospitalization, but not for mortality. And that's really something that you have to consider before you bring the patient to the table. It's more or less a quality of life and a reduction of complaints therapy. And we have a problem, I think, with non-ischemic cardiomyopathy because it's so much depending on the etiology. And no matter which etiology, still these patients are a headache. And I think we have to really continue to do research to better understand their substrate. And for the new ablation tools, I think deeper lesions, more sustained effect. We have some things in the toolbox here, bipolar ablation, as I showed you, or the needle ablation, but that's something to come. And I think we can there even increase the success rate of the VT ablations. So thank you for your attention.
Wonderful talk, Isabel. We have two questions, one from me and one from the audience. So the audience has asked, what do you think of MRI-guided ablation?
Yeah, I mean, especially in VT, it's so, it's attractive because you could see really these scars and could really see online how you are approaching that scar and not completely dependent on these electrograms, which might not show a low voltage there. On the other hand, it's technically so demanding, and there are a lot of restrictions to the recording quality and everything else. And in the end, I think it's fantastic for some patients, but for the majority of patients, I think it's just a technical overkill. It's just too complicated.
Well, that leads very nicely to my next question, which is, as we get more complex with these procedures, what's your reading of how that's affecting the mortality and the risks of the procedure, and how do we get the balance between a really complete procedure and a safe procedure?
Yeah, that's always in VT question, ablation, always the question, and that's why I was so fascinated by that study from Madrid, where you could see that the induction is not necessary to do the ablation, because that means that we do not have to induce these VTs during the ablation, but we can sort of do this very, chilled in sinus rhythm, and then we have less risk for the patient. But still, it's always like waiting. Okay, this is a patient who is in serious problems with his arrhythmia, but how much problems will I create by the ablation? And I think everybody of us has one or two patients where we thought afterwards, I shouldn't have done that. And maybe also some patients where we thought, maybe I should have ablated him or her. So I think it's an extremely difficult decision, and it has to be a patient by patient decision, really an individual decision.
I definitely know that feeling. Hindsight is a wonderful thing. Well, thanks very much, Isabel. We now move on to our next speaker. You'd be hard-pressed to find someone that knows more about hands-on AF ablation than Julian Chun, and he's going to be talking to us about current and new technologies and for simplifying AF ablation. Julian.
Dear Richard, dear Isabel, dear organizers in the background, thanks again for setting up this very fantastic meeting. And I am also pressed a lot to kind of report on all what's going on in the field of novel technologies and catheter ablation of atrial fibrillation. So we move on to the atrium, and these are my disclosures. And this is where we come from. And I believe in many labs all over the world, the mother technology and the mother approach is somehow related to a 3D mapping device system and catheter RF energy, maybe with contact force, maybe without contact force, and encircling the pulmonary veins, maybe using some indices as we discussed yesterday. Or on the other hand, and that was, I think, a major step forward over the last years, the introduction of balloons into the arena of AF ablation. And it's especially the cry balloon, but also laser balloon and other devices, which I will talk to in a minute. So therefore, this is my agenda. And I want to start off, of course, with RF ablation. And RF ablation also, of course, offers a lot of potential. And the new latest concept, or one of the latest concepts, is the so-called high power and short duration ablation within the atria, and especially for the application of atrial fibrillation. And it is because of the fact that it came out and it was shown in different bench data that high power, ablating with high power, for instance, 70 watts for a shorter duration with a given contact force results into a more shallow and not that deep lesion, and therefore maybe allows the operator to have a more contiguous lesions within the atria, and therefore may have to come up with a faster circle and more, maybe also with a more durable circle over time. And this concept is challenging and it's very interesting because on the other hand, we may also think of having potentially lower side effect damages, such as maybe burning into the esophagus. And this is one of the new kids on the block, which is the so-called Q-dot catheter. And the Q-dot catheter relies on 6 thermocouples, which are mounted on the tip of a catheter, a lot of micro electrodes, making sure there is surround flow, and there is a temperature-controlled ablation, which is relying on those 6 thermocouples with real-time temperature monitoring. And a specific algorithm allows power control to maintain a certain target temperature. And this Q-dot is a pretty, let's say, interesting mode, and a Q-dot plus mode going for 90 watt, 4 seconds, a very short application. And this is a case which was done in my home university in Lübeck, and it's courtesy of Roland Tilz and Christian Heger. They did this week a case and amazingly finished the case in 54 minutes, ablation RF time, 5 minutes, 300 seconds. So this is very, very fast. And you see these clear and nice, very precise circles encircling the ipsilateral pulmonary veins. The Q-dot also demonstrated in initial human experience in a more systematic fashion that it was able to reduce procedure time, total ablation time, total fluoroscopy time, and total RF application duration down to 8 minutes in this work by Vivek Reddy and co-workers. In Frankfurt, we did something a little different because we were not able to have access to this technology at a very early time. And therefore, we thought, okay, we listened to Matthias Duchever because he introduced the idea of ablation index and contiguous linear lesions going for target indices, but we combined it with highest power our generator was able to give, which is 50 watts. And then we went for this ablation index controlled high powered short duration ablation approach, 550 anterior, 400 posterior wall. And as a result, the RF time per procedure was 12 minutes. The first pass isolation rate was 95 per circle. Ablation duration procedure time skin to skin 54, fluoroscopy 5.5 minutes. So that we felt also not too bad. But the maybe even more interesting aspect of this is in the a larger series of more than 122 patients in which we did scope most of them, we found that in only 3.5% of those patients using 50 watts for a short duration at the posterior wall, lesion in the esophagus was detected. And that was, or is at least supporting the idea of high power and short duration from my perspective. balloons. Balloons, of course, entered the arena a couple of years ago, and these are a lot of new kits on the block. Apama with RF and a camera, globe catheter, the Helios, which I will go into some detail, and the new cooling catheter, the PolarX from Boston. We were often asked, what is, from your point of view, the better balloon? Is it the cry balloon or is it the laser balloon? And we could never really answer this question because there was no randomized data. And this is why we set up this trial, 200 patients, which we included 100 patients paroxysmal, 100 patients persistent atrial fibrillation, one-to-one randomization cryo to laser balloon. And then we found out and we could observe that the outcome after 1 year was exactly the same between both devices. So the 12 months freedom from atrial tachyarrhythmia was exactly the same, was not different. However, procedure times were significantly shorter, 50 minutes versus 96 minutes for the cryoballoon. And this is why we're very interested in the recent advent of the latest update of the laser balloon. It's called X3, and the X3 idea is to move on from point-to-point ablation to almost a single shot application. This is what you see here. You see into the beating heart a 360 view, and you see that the vein can be encircled, and thereby a single shot can be obtained. And using this technique with a motor unit, we could demonstrate that procedure times came significantly down to 50 minutes. And this is, I believe, a potential major step forward for the laser balloon. The most recent new kit is Heliostar. It's an RF balloon, and I know, Richard, you have some experience with this. 28 millimeter irrigated gold electrodes, 15 watts ablation, and available with a circular mapping catheter as well. And it also offers the chance for segmental and individualized ablation, as you can see here. Initial data showed pretty nice procedure times, 100 minute, less than 20 minute fluoro procedure exposure, and most of the veins could be isolated with the device only. However, in some cases, it's still temperature rises and potential lesion in the esophagus remained an issue. And the first version was only guided with a guide wire, and the latest update came out with a mapping catheter, a mapping tool itself, and this is shown here. And you can also use this tool to observe time to isolation. And time to isolation can be observed along with single shot in a very high rate of PVs. And this is the very initial data. I think this is therefore a really promising new tool. And initial follow-up is also in line with what we would expect from such a balloon PVI device. We started in Frankfurt yesterday, actually our first cases. And today we accomplished a total of 6. And this is a map pre-ablation. And I was really surprised how potential, how strong and how big lesions this balloon is able to create in a PA view post-ablation. And this is why my friend and colleague Barts and I, we look very impressed. What else is new in the future? And very briefly, I want to add, or I want to mention the Adagio device, ultra fast cooling up to 196 degrees, a device which also allows real-time visualization, single shot. And this is something which is worth to investigate in future. Of course, electroporation is the big thing, the big new thing, maybe hope or hype, because we know it is very powerful. It can be in different catheter configurations, positioned in different areas within the atrium. And we know there's also different catheters, different companies are working on this. This was tweeted by Atul Verma. This is the paper from Vivek. The fascinating observation is that using a certain recipe, 100% of PVs remapped were isolated. You need to come up, however, with a certain recipes. But if you use that certain recipe, all veins remain isolated, and this is very difficult to beat. And apart from that, it also appears that it's not only creating very selective cardiomyocyte necrosis, but it also leaves surrounding tissue like the esophagus and the phrenic nerve apparently intact. So 100% durable isolation. It's very tough to beat. Looking forward to more to learn into the future. Another very interesting toy or tool is the lattice catheter, which allows to toggle between RF and electroporation. And also initial human data came out proving the concept of the lattice catheter. So therefore, ladies and gentlemen, I would like to conclude. Number one, RF current ablation is our mother energy source, and it's definitely refined, and we have more options these days. Balloons in AFib ablation are definitely established, and they found their role in daily practice. Novel tools and a variety of novel tools are coming, they are underway, and I believe that especially electroporation is of very, very great interest, and I'm very much looking forward into more data over the next years. But still, and this is something we all need to keep in mind, despite of all the enthusiasm for all technologies, all these new players still need to prove a clinical benefit for our patients. Thank you very much.
Great talk, Julian. And I, like you, am very excited about the possibility of electroporation as well as other things that can be mounted on one-shot systems. Can I just ask, though, one of our audience has asked, in terms of long-term outcomes, do you have a feel that one energy or technique does better than another, or is it still too early to tell?
It's always too early to tell if you talk about new technology and new strategies, of course. But from let's say my current understanding, and if I look, let's say, at it from a more global perspective, I believe that an anatomic device, such maybe the cryoballoon or any cryoballoon, is also proven and linked to a very high rate of a durable pulmonary vein isolation, which is still at this point in time, our best endpoint for the index of AF ablation procedure. And due to this fact that the human factor with such an anatomic device, the human skill, is not that important anymore, I believe that from a global perspective, a balloon device, maybe cryo is a very, very good device for a durable isolation, and therefore also with a very predictable and very good outcome for our patients. This does not mean that, of course, using RF and very skilled centers can be even better and has more applications, doing also additional targeting different areas, etc. But for a PVI-only approach, I think a balloon, cryoballoon, or laser balloon do excellent durable PVI.
Well, that leads me nicely on to my next question, which is we've talked about how we get durable lesions, but we had a real debate yesterday about what we do about persistent AF. Do you think that there are any technologies out there that may help us to find where the sources are for persistent AF?
This is the unknown question, and this is the $100 million question, basically. If we knew what to add and maybe to individualize for a patient to identify critical regions, either based on imaging or based on electrogram information, we all would be one or at least 2 or 3 steps further ahead. But I don't have this perfect answer, of course. I don't have it either yet. But I think we will have over in the program today also a very interesting approach combining the surgical approach, basically going for a posterior wall ablation. And this, I think, is very interesting, and maybe we can also come up with technology doing this with percutaneous devices in future.
Great. Well, thank you both very much. That's the end of this session, and I'm going to pass on to Isabel for session 2 on the live case.